I have written courses on atrial fibrillation. The graphic is really easy. You've got lone, paroxysmal, you have permanent. And I am under the impression now I have to change the graphic. In the May 6th issue of JACC, you can read Lone Atrial Fibrillation, Does It Exist? A white paper of the Journal of the American College of Cardiology. And I am with one of the co-authors of the paper, Dr. Sanjiv Naryayn, and you are MD, PhD, and Professor of Medicine in residence at UCSD and Director of Electrophysiology at the San Diego VA. So, do I have to rework this graphic? I've been using it for years now. I have a feeling it's gone.
I think that the graphic still has some value, but I think largely the term lone AFib is a term that is being relegated to the history books.
So what we really find out now is that lone AFib is not so alone. It usually has some company.
We're never alone, Rick. But
yes, exactly. Isn't that the truth?
So I think the way that we look at it is that atrial fibrillation has different time variations of how it presents. And so I think what you said in your graphic of paroxysmal, let's call it persistent and long-standing persistent, or you could say paroxysmal, persistent and permanent if you wished, I think that still has value. That talks about AFib that stops and starts or doesn't. Lone AFib was always thought to be a condition which existed where AF existed without any other heart condition. The problem is, as we learn more and more about the condition, we learn that so many other factors we previously couldn't detect are actually associated with AFib and may actually impact therapy. And as a result, the term lone AFib is largely we recommend in this manuscript, based on a careful analysis, that it's probably time to put it to rest. So this was basically a task force and a position paper by the American College via the Journal of the American College, and we examined the data from the point of view of mechanisms, from the point of view of clinical practice, from the point of view of epidemiology. And we said, does the term lone AFib help you treat a patient? And we came to the conclusion that if you look at some studies, lone AFib is defined in one way. If you look at other studies, lone AFib is defined in other ways, all of which vary. As a result, they often don't encapsulate the things that are most important to therapy, and therefore it doesn't have therapeutic or mechanistic value.
So the idea is, if you see what you think is what would be lone AF in the old days, you haven't looked close enough, because there's probably something there.
Yeah, so lone AFib in the old days would sort of give you some sense of reassurance that everything was basically fine. Whereas, of course, now we know there are many factors associated with AFib which weren't embodied in that. For instance, you could have diabetes, which is not technically a heart condition. You could have a normal echocardiogram, you wouldn't have hypertension. But we know that diabetes is 1 point on your CHA2DS2-VASc score, and if you're a woman, then that gives you 2 points, you need anticoagulation. Therefore, by definition, it's not benign. And so, although that somebody who has atrial fibrillation, who's a lady with diabetes, may have a normal echo, that person needs to be treated in an intermediate risk category. Again, the lone AFib category doesn't apply. If you look across the board, we feel it is more valuable. And we actually think the field is moving towards talking about paroxysmal, persistent, long-standing, and then just risk stratifying risk for stroke based on the CHA2DS2-VASc score, the risk for bleeding based on the HAS-BLED score. And so again, the notion of lone is sort of falling away.
And it's actually good news, because it just means we're doing a better job of detecting these previously undetectable problems.
We're doing a better job, and it's much more effectively translated into treatment. I think it's easier in many ways.
Well, if you've not read the paper, I think you really should, because this is an issue, and it's a white paper, after all, that we're putting together from the Journal of the American College of Cardiology, and it is in the May 6th issue of JACC, and I definitely will go back and rework that graphic. There's no doubt about that. For CardioSource World News, I'm Executive Editor Rick McGuire.